Good morning. Okay, we have Dr. Wiltek, and I think we'll get started. So I'll start here with our first case. In this case, we've got a 48-year-old gentleman who is patient of Dr. Komatar, referred by an outside ophthalmologist who he saw for double vision. Went to Bascom Palmer. Visual exam there was found to have a left homonymous hemianopia, pardon me. No changes in his visual acuity. Some other things to know about this patient. We'll go to, do we have Mike Silva? How about Cadbury? Okay. I think some of the residents are still logging on. We'll keep moving here. Helpful things to know: somebody has a new homonymous hemianopsia. How long has it been going on is a good question. Obviously, always important to know if there's any history of malignancy. In this patient, it's really not clear how long the symptoms have been going on, because he didn't really notice that he was having the hemianopsia. So just to review, lesions of that can cause this visual deficit is either the distal optic tract, optic radiations, or within the calcarine fissure. Here we have some imaging that was done at Bascom Palmer. Let's see, Victor Liu, are you able to describe the MRI here?
Yeah, hi, this is a right-sided posterior contrast-enhancing lesion located in the occipital lobe.
Great.
Differentials include meningioma and metastasis.
Okay, good. Can you think of any other dural-based lesions that would be homogeneously enhancing?
No, I can't think of another one.
Okay. Good, I think we covered that. Another thing to notice is that there's prominent flow voids on the MRI. That can be a bit of a tip-off for ultimate diagnosis. And I'll go back to, on a lesion like this, especially it's kind of parafalcine, it's important to notice whether the superior sagittal sinus is involved, and you can see pretty clearly on the middle image that it is. So differential, you've got a lot of these. Among dural-based metastasis, prostate and melanoma are the top two. Lymphoma, gliosarcoma, hemangiopericytoma are other malignancies that can arise from or be stuck to the dura. So let's see, do we have Michael Silva now?
Here.
Hey, Mike. So tell me, just looking at that MRI, what would your main goals of surgery be?
Remind me her vision again, or his vision?
Yeah, so the vision is 20/20, but there's a left visual field cut. And just looking at this, tell me a little bit about what the way you'd position the patient and what you'd be trying to do in the surgery.
Yeah, so yeah, goals of surgery, definitely tissue for diagnosis. It looks like it's you may want to. I'm not sure his vision's going to improve, but it's definitely symptomatic. So you want to take it out as much, a gross total resection if you can. It looks pretty vascular, so the dural base looks to be on the convexity. So hopefully you'll be able to coagulate a lot of the vascularity initially. You may want to position the patient with the right side down in the lateral position to be able to follow the the falx and access the medial side of it.
Yeah, good. Yeah, and you're right. This case they did prone, but I think lateral's reasonable. Another thing you can think about is a lumbar drain. Can give yourself more room to work. And yeah, I agree. I mean, regardless of the diagnosis, your goal in this case would be to try to get as complete a resection as possible. And then we already noted that the tumor is involving the sinus. So if the sinus is patent, you need to be careful there. And I'll let Dr. Gultekin take over.
Yeah, so as it was mentioned in the differential diagnosis, this was not a meningioma, but unfortunately an anaplastic hemangiopericytoma. The buzzword for that is, cellularity and the blood vessel pattern called staghorn. These are dilated, thin-walled blood vessels that are very typical of the morphology of, you can see 3 or 4 of them right here. So next slide, please. Yeah, so on high power, again, in this case, unfortunately, there was a certain clone that probably, expanded, that is really malignant looking, big cells, prominent nucleoli, tons of mitoses. Next, which will be good for anaplastic designation. In other areas, there was a more low grade looking picture. Next. And the key to diagnosis here is the immunohistochemical stain that shows STAT-NAB2 fusion. So STAT6 revolutionized radical morphological diagnosis of hemangiopericytoma, solitary fibrous tumor spectrum. And if this stain is positive, which is nuclear marker, it's a transcriptional activator, and that is actually being labeled here. So when this is positive, you know that you have either a solitary fibrous tumor or hemangiopericytoma. These are now found to be a continuum of biological, entities. The common denominator being NAB2 STAT6 fusion, so, if this is negative, we cannot talk of hemangiopericytoma. So here we prove that it is. Next. CD34 is focally positive. CD34 positivity is more strongly seen in the benign or more benign form of these tumors, more in the solitary fibrous tumor, which this is consistent with because this is only focal staining and we're talking about hemangiopericytoma. Next. Ki-67 was high. Here it looks like 10%. Next. Mitotic figures are abundant. In one high power field, you see 4 mitotic figures. So this is designated as an anaplastic hemangiopericytoma, WHO grade 3. So that's it.
Okay, thank you.
Sure thing.
Yeah, so just a few things clinically about hemangiopericytoma. Like a lot of other tumors that we see commonly, overall survival's directly related to the extent of resection. The overall survival is around 80% at 5 years, although this, in this particular case, is probably more aggressive. 10% of these can metastasize. And it's certainly something we see. It's about 40 times less common than a meningioma. When there is residual tumor, radiation is helpful to prevent recurrence. And when the disease does recur, it's typically treated with chemotherapy. So moving on to our second case. In this case, there's a 60-year-old gentleman who's had progressive myelopathy, who presents with left greater than right lower extremity weakness. He's noticed that over the past few days to a week, he's been falling when he tries to walk. No past medical history. On his physical exam, cranial nerves are unremarkable, but he does have weakness in both legs. We grade distally in the right leg, 1 out of 5, 4 out of 5 distally in the left leg. Let's see, do we have Kat?
Hi, good morning.
Hey.
So it looks like there's
Describe our CT.
yeah, this is a sagittal CT of the thoracic spine. Looks like there's a compression fracture or flexion compression at about probably T4. It's probably pathologic.
Right. Yeah. It's hard to tell in this image, but that's it. T3.
T3, okay.
And then this is the MRI.
Yeah, this is the sagittal MRI of the thoracic spine T2C that shows ventral and dorsal mass around the spinal cord, causing cord compression and some mild cord signal change.
Right. And would you say that the fracture looks stable or unstable?
It looks acute, and it's probably unstable since there's edema in the posterior elements too. And it goes through the entire vertebral body.
Yeah, definitely. There's involvement of the posterior elements for sure. And as you said, there's severe spinal cord compression. When the vertebra is flat like that, sometimes radiologists still call it vertebra plana. So what's your differential diagnosis?
The one I mentioned already, pathologic fracture. It could have non-pathologic fracture, but I don't think so after that MRI. And yeah, multiple myeloma, abscess, hematoma, epidural, angiolipoma.
Yeah, definitely. And it can be really hard to tell the difference between multiple myeloma or metastasis in the spine. And then there are some other things, but I agree those are definitely less likely. What would your surgical approach be in this case? And what do you think?
Josh, before you go there, you'd mentioned the multiple myeloma. Do you want to comment on what is the most common diagnosis if somebody comes to the ER without a history of cancer?
Yeah, definitely. So we just reviewed this in a series, and if you essentially you're seeing someone in the ER who has a new pathologic fracture that requires surgery, the most likely diagnosis, the majority of those patients will have multiple myeloma. In our series, it was over 50% of people who came to the ER basically needed surgery. And it's important that it's without any known diagnosis. Those turn out to be multiple myeloma. So based on that could really be your top of your differential here.
And it's above a certain age, probably, right? Your findings?
Yeah, this was definitely in adult patients, and I think all the patients in the series were older than the age of 40 or 45.
Yep.
So the surgical approach would probably be a transpedicular decompression at T3, and then you'd probably need to fuse at least one above and below or two, depending on the bone quality.
Yeah, definitely. And that's what was done. You know, the goals in these cases is definitely to remove the compression of the nerves and spinal cord, and then, as you said, to stabilize. And that's just what was done. There's different ways that people will manage epidural spinal metastasis, but I came across this sort of treatment algorithm, which is helpful. It basically just says that in patients with disease that's relatively stable, who are at a reasonable functional status, what it really comes down to is what the degree of extension of the epidural disease is. If there's spinal cord compression, then you know, you look at whether or not the tumor is likely to be radiosensitive. Of course, that's in cases where you know what the disease process is. But I think it's worth knowing that there are people who will radiate pathologic fractures even if they're unstable, because they find that those patients still tend to heal. I don't want to spend too much time on this, but there's a lot of ways that people approach this problem. However, if there's a new deficit and it's less than 8 hours after the deficit started, then most people agree that surgery is the right thing to do.
So, yes, can you move on to the next slide? Yeah, so the smear prepping during the operation was these epithelioid cells, which also ironically a little bit look like plasmacytoid too, which is a problem because it may be difficult to tell between multiple myeloma and metastatic carcinoma. Next. The permanent sections show bone with foci of metastasis. So in the middle, that little island, that purple island, is a bunch of metastatic carcinoma cells. Next. So it was a metastatic carcinoma, and you can see on high power the plasmacytoid features. This is a term that we use for neuroendocrine lesions that look like, you know, plasma cells sometimes because of the eccentrically placed nuclei. And so this is not a multiple myeloma. This is a neuroendocrine carcinoma. Next, and now the immunostains will show that it's keratin positive, which confirms the epithelial nature. Next. And CK7 is more like above the diaphragm type of epithelial tumors, such as lung, thyroid, and others. TTF1, thyroid transcription factor, is positive, which again can be seen in lung and thyroid cancers. Next. Synaptophysin is positive. This proves that there is an endocrine element to this tumor. Next. And interestingly, calcitonin was positive. So at this point, I scratched my head and said, And the next one is CEA, carcinoembryonic antigen. So I said metastatic neuroendocrine carcinoma, likely origins include lung and medullary thyroid cancer. I don't know what happened afterwards. Did you guys find a lung lesion or a thyroid lesion?
In this case, the patient did have some primary lung tumors.
Right. So the calcitonin can be explained then as a paraneoplastic, expression of which is a known phenomenon in lung tumors. If there were no lung lesions, then you would have to look at the thyroid. Okay.
Yeah, and just a couple other notes on metastatic lung cancer to the spine. Lung cancer is one of the most common, and then there's the old adage, the lung Mets in particular tend to go where there's a good vascular supply. So a lot of the time they'll be focused arising from the vertebral elements where there's a good blood supply as opposed to the disc space. This particular type of lung cancer, it would be classified as non-small cell, but tends to behave like small cell in that it's somewhat radiosensitive. It's fairly rare and fairly aggressive. There's a number of reports actually in the literature of this being a type of metastasis that occurs intradurally. And I listed a couple of them here, but there were certainly others. I'll move on to the next case. It was a 48-year-old woman who presented again to Dr. Komatar's clinic. She'd had a seizure once a week ago and was placed on an anti-epileptic medication at another hospital where an MRI was done. Her physical exam in the clinic is unremarkable. Damien, are you with us? Let's go back to Mike Silva.
Yeah, I'm here.
Yeah, Mike, what do you see on these MRIs?
So the left image is, looks like flare abnormalities in the left temporal lobe, a little bit of like enlargement of the gyri, and I don't see any obvious contrast enhancement.
Okay, good. Do you want to take a stab at what we're looking at here?
So I think some sort of low-grade glioma would be highest on my list. How old's the patient again?
This patient's 48.
Oh.
Yeah, so I think you covered it. Non-enhancing left posterior temporal lobe. There's not much edema or mass effect that would point to lower grade tumor. For differential, you'd mentioned low grade glioma. What are some of the variants of low grade glioma that it could be?
I mean, you got them up here, but yeah, an oligo, astrocytoma, yeah.
Yeah, definitely. You know, some of these would be less likely based on the patient's age. A DNET, for instance, or ganglio tend to be in younger patients. Same with PXA. This patient's 48, so wouldn't really be classified as a young adult. So it doesn't fit perfectly with those. And someone this age, we may think more along the lines of astrocytoma. What would your next steps be once you have the necessary imaging?
So yeah, goals for this patient is you want tissue for diagnosis, and she's had a seizure, so she's, I guess, symptomatic from it. The issues are that it's the dominant temporal lobe, so you know, you could cause you know, morbidity with the resection, but I would recommend surgery for her.
Yeah, is there any type of monitoring or anything special that you would do during surgery for a tumor in this location?
I mean, I guess the usual, like, motor and sensory monitoring. You'd be worried about her, I guess, language as well, but.
Yeah, definitely. I think, you know, for a tumor in this area, it's appropriate to do speech mapping as you go along, so that you get maximal safe resection. And then, yeah, I think motor and sensory monitoring in this area as well.
So, this was an interesting case. I wanted to make sure that we had a mass because it looked almost like dysplastic cortex on the top. And you can see here the darker pink area at the bottom corresponds to the white matter. And the top is at the bottom, this lighter pink arcuate area. So this is the low power, and at first look, you could say, oh, what's wrong with this? This is just normal cortex and white matter. But when you look high power, please, next. Yeah, so you can see that there are these abnormal cells, a big population of cells with pink cytoplasm and eccentric nucleus. Next. There is vacuolation of the neuropil. Next. And very abnormal looking background with like chunks of or tufts of the background neuropil. And there is a Rosenthal fiber in the center, this red big chunk. We are getting close to it. In the center left, yeah, getting close to it. Bigger one, a bigger cell, bigger than your arrow. Yeah, that one. So some Rosenthal fibers, which are hallmarks of slow-growing lesions and even sometimes reactive lesions. Next. Well, here's the punchline. You can see that there are neurons with multiple nuclei. Like in the center, you can see 2 cells at least who have double nuclei. These are neoplastic ganglion cells, okay? And there was no glial component, so I didn't call it a ganglioglioma, I called it a gangliocytoma. This is considered to be a grade 1 tumor. It's uncommon. One form of it is seen in the midbrain. You can see a gangliocytoma in the midbrain sometimes. And of course in the temporal lobe, typically mesial temporal lobe, one of the common locations. So it's good news for him or her. Next. So the immunostains will confirm that these are ganglion cells. This is an HUCD stain, an early marker for neuronal commitment of stem cells. Very nicely positive in those cells, abnormal cells. Next. Neurofilament shows abnormal thick fat processes of these abnormal neurons. Next. Synaptophysin shows these patchy areas of paleness, which is very abnormal. Gliofibrillary acidic protein was negative. I didn't show a slide. So these cells did not express GFAP, therefore, we're not talking about a glioma here. Next. Okay, done.
Yeah, so gangliocytoma, this in the literature is more commonly seen in children, and it's frequently discovered as the cause of epilepsy, as was the case with this patient. And as Dr. Gultekin mentioned, these tumors lack neoplastic glial cells, and if you look at images of these tumors, they can look a lot different from the way that this one looked on imaging. It's not uncommon for them to form cysts and enhance, so a lot of them can look more like a PXA. As with many low-grade gliomas, resection is curative, and just as an aside, Lermite Duclos is one that you come across commonly on board studying, and it has a similar name. There's gangliocytoma in the name, but it's not. It's a different disease process and would be considered a different type of tumor. So just to avoid confusion there. And then, as I mentioned, the appearance can be pretty different. So this is just some examples from the internet of some other patients with gangliocytoma. You can tell that these are also MRIs from kids, but they can also be cystic and they can also enhance. So tissue diagnosis is really the key on these.
Do you happen to know how this patient is doing now after surgery? Deficits?
No, I don't believe that the patient had any documented deficits. I'd expect maybe a quadrantenopsia based on where the tumor on the tumor was, but I think the patient did well.
All right, interesting case. Next one.
Okay, moving on to our fourth case. This is a case of a 73-year-old gentleman who was admitted to the stroke team with a 1-week history of headache and right arm weakness, which got progressively worse over the course of the week. His family, who he lives with, noticed that he had new gait instability and was having trouble performing normal activities. It's a guy who'd previously been living independently and not requiring assistance for those. No past medical history. Physical exam, he is awake and alert, but confused. So he can follow some simple commands, but if you were to try to talk to him about the day or the weather, he would have trouble. He has a right lower facial weakness and some pretty profound weakness of the right arm. Mike Cater, can you maybe localize where the lesion could be, if there is a lesion and it's not a stroke?
It could be in motor cortex, farther laterally away from, kind of like in the hand arm area. Could also be in the cervical spine.
Yeah.
But more likely, in the motor cortex, considering he also has lower facial weakness.
Yeah, good. Yeah. With the assuming there's one lesion or stroke that's causing this, you would expect it to be exactly near the motor cortex. A lesion in the spine, you would be more likely to get arm and leg involvement, but that wouldn't expect that you wouldn't expect the facial weakness. So good. I think we covered that. And then the only other thing, a stroke or a lesion in the motor cortex alone wouldn't necessarily explain the patient's behavior and confusion, right? So you have to think about what else could be causing that. If it's a tumor, then you'd want to rule out hydrocephalus. So next step would be to get a scan. So, Mike, can you describe what we see here?
Yeah, so there's a hyper dense lesion. Looks like it's arising from the left ventricle. Looks like the ventricle's trapped. He's got marked hydrocephalus of the temporal horn and transependymal flow. Yeah, definitely. So what would your next steps be here? Get an MRI with and without contrast. Okay. Yeah, and I think that's a reasonable choice. If the patient's awake and talking, which this one was, in this case, given the degree of the dilation of that trapped ventricle, we actually opted to place a temporal EVD
first, sort of to temporize so that we could do the rest of the workup. And then also, you know, for a tumor in this location, anti-epileptics are important as well. And so this is the MRI that was done after placement of the ventriculostomy. Do you have any thoughts on what type of tumor this could be in a 73-year-old?
I guess could be intraventricular meningioma, could be central neurocytoma. Unlikely to be a choroid plexus papilloma, considering his age, and that location is usually seen more in the pediatric population.
Central neurocytoma would be unlikely given the age.
Okay.
Right. So meningioma, I think, is definitely would be close to the top in a patient this age, but you also have to think about metastasis. Intraventricular metastasis do definitely occur, and you can think about some of the stranger stuff too, like cysticercosis, lymphoma, tuberculoma, and as you mentioned, a choroid plexus papilloma. You really wouldn't expect to see an adult in this location. Usually in adults, a choroid plexus papilloma would be in the fourth ventricle. In terms of dealing with this lesion surgically, can you name what some of the options would be?
I guess you could approach it posteriorly and come through the ventricle, through like the occipital horn, and I guess try to take out the feeders first, and then try to take it out and block. You could also come from above, maybe like a interhemispheric, and try to get to the ventricle that way. Or you can come anteriorly and kind of work backwards.
Yeah, and I think that those are reasonable choices. What they ended up doing here was using the tubular retractor, basically, to get to the tumor. And since it was well circumscribed, it came out that way. And as you mentioned, you know, getting control when you're working in the ventricle like that of the arterial feeders is definitely important. Which what do you think the primary blood supply would be for the tumor in that location, the posterior temporal horn, sort of on the atrium?
Probably the lateral posterior choroidal artery.
Yeah, definitely. I could see if I go back. Yeah, it would be the lateral posterior choroidal. The anterior choroidal wouldn't come up that far. That's more kind of the anterior temporal horn.
So next slide. So you can see here glandular structures. This is obviously from the very first slide. Metastasis, unfortunately, metastatic adenocarcinoma because of the glandular configuration. Next. Under high power, you can see the malignant nature of these glandular cells with prominent nucleoli, enlarged nuclei. Next. And it is TTF1 positive once again, which is characteristic for lung and thyroid. Next. CK7, also a keratin that is expressed in tumors above the diaphragm. Next. So, yeah, we thought that this would be most likely lung, and I don't know if the patient had known lung. I missed that part. Hello?
Yeah. So
You got-
in this case, it was a lung primary. The
Okay.
patient had a CT chest, abdomen, pelvis just before surgery that showed that there were some pulmonary nodules. This case obviously being fairly unique in that there was intraventricular metastasis. Lung cancer is the most common to metastasize to the brain, so makes sense that it would be the most common to metastasize to the choroid plexus. But like we talked about earlier with the epidural tumor in the spine, blood supply is very important for these tumors. They have a high metabolic need. So the choroid plexus is what it would be attached to within the ventricle. This particular tumor was a type of non-small cell lung cancer. So just to review, in patients that have non-small cell lung cancer that is otherwise controlled, there's a low risk of recurrence, and these patients tend to do better with surgery. The main predictor of outcome in these patients is going to be how they do with their primary disease.
Josh, just to interrupt, just one thing, I think just for the juniors, the most important part of this case too was the fact that the patient presented obtunded with this huge temporal horn. I think that the EVD, the temporal EVD that you placed, really kind of temporized him to allow him to get the MRI and surgery. If you let that temporal horn go and untreated, the patient could easily herniate. So, if you show the initial CT scan, so that was a kind of an important point, I think, of that case. And your EVD in the trap temporal horn was, kind of helped give us more time. So, just another small point for.
Yeah, definitely. I think that it really, it's important to understand that the management in these patients is completely different when you have a tumor within the ventricle that's causing hydrocephalus. And then moving on here to our last case, this is a patient of Dr. Morcos, a 79-year-old gentleman who had loss of visual acuity in the right eye over the past year. And he didn't notice it, but his family noticed that he'd had some bulging of the right eye, past medical history, some of the common maladies that you would see with a gentleman this age. On physical exam, he's got restricted abduction of the right eye, so less movement of the right eye with lateral gaze. He's got some decreased visual acuity in that eye, and otherwise, pretty unremarkable exam. Victor, are you logged in? It's all right, we'll keep moving. Our next steps obviously are going to be to get appropriate imaging, depending on how the bulging eye looks. You may consider an infectious workup. Could it be some type of infection or cellulitis, pathology of the orbit? Unilateral proptosis, it's less likely to be an endocrine issue, but that's another thing to consider. I have MRIs pulled up here, and this one's interesting because there's actually also a video that goes with it.
Órale, vato. He skydived once without a parachute and survived.
He gave the Dalai Lama lessons in meditation and wisdom.
He once clipped an aneurysm with his teeth. He once melted a tumor just by looking at it. He is the most interesting man in the world.
I don't always give compliments, but when I do, I really mean them. But stay thirsty, my friend.
That is hilarious. I love it.
Wait a second, it's not done. So who is this man of mystery that was born 60 years ago today? We are honored to pay tribute to him. You can see from this picture here that he was rather precocious for his age. You can see his stare, and he was born with a mustache. Was born in Lebanon under pretty austere circumstances, and that was carefully discussed in a recent paper of his. Any of you who work in the operating room with Dr. Marcos will recognize this pose with him sitting on a throne asking for instruments. And you can see this started at a very early age. This is Jacques a little later on. You can see that he literally has 6 women, trying to get his attention, and he's fixated on a stain on his shirt. But then he grew into a man, had some quite odd preferences to start with. This album from the 60s and 70s typifies that. But he was heavily influenced by the Bee Gees in the 70s. You'll see this classic pose a number of times in this slideshow. He definitely was a ladies' man, and that we now recognize. He had lots of experience. He's seen here stealing a woman right under the nose of an Argentinian dancer. You can see that Jacques is happy and the dancer is not. And this is when he finally met the woman of his dreams, Fiona. You can see him here meeting her father for the first time. You can see, by the way, her dad is grabbing her. He's not too anxious to let her go to Jacques. And then they married 30 years ago during his training in England. And unbelievably, Fee still has a smile on her face and has been able to tolerate Dr. Marcos for all these years. Way to go, Fee. You can see that Jacques has some characteristic poses and mannerisms in these 3 pictures. What is up with that leg, dude? I don't get it. But this is where we know him, seen here 55 years later on his throne, doing the things he loves to do, which are skull base and cerebrovascular surgery. One of the other things that he loves to do is teach. He goes around the world internationally, teaching neurosurgeons how to do the surgery. He's been the past president of numerous societies, including the North American Skull Base Society. Here's a picture of him in Afghanistan teaching the Afghani neurosurgeons, and you can see this young gentleman to his right employing some of the techniques he's learned of skull-based surgery. Here's a picture of Jacques with his family from about 10 years ago, and a more recent picture seen here with his lovely wife Fee and his 3 older children now, and their most newly acquired family member. So this is the beginning of a roast. And happy 60th birthday. We did want to give you and present you with some birthday gifts. First of all, on behalf of the department, you know, as you're getting older, I know that you will have more and more falls. So we wanted to get you a bracelet and a necklace so that you can buzz people when you have trouble getting up. That's actually what we wanted to do, but unfortunately budgets are tight and we couldn't afford the monthly fee. So we've gone to this whistle that you can use if you fall. Of course, we want to get you a 1-year supply of Viagra that we will pay for. And then we have a little gift basket for things I know that you're going to need, diapers, you know, a pill dispenser box, you know, lots of bingo cards and eyeglasses for reading. And then I know that you never listened to me, Dr. Levy, but I know that you would take final advice from Dr. Seuss on aging. I cannot see, I cannot pee, I cannot chew, I cannot screw. Oh my God, what can I do? My memory shrinks, my hearing stinks, no sense of smell, I look like hell. My mood is bad, can you tell? My body's drooping, have trouble pooping. The golden years have come at last. The golden years can kiss my ass. And he's now here coming out of off his bike and known as the Brain Whisperer to all of us. And enjoy these next couple of videos.
It's coming out. So tell anesthesia more. Hold on, stay online. Tell him, hello. Ika Morcos.
So Brandon,
Mr. Jose Cartagena.
he's on the phone with someone else.
I guess even though somebody told me he ate half a banana or something. No. What do you mean? We took the train.
Only time I've ever seen him upset is when his patient
Somebody
half a
told me
banana.
he ate half a banana or something. No. What do you mean? We took the train. It's coming out.
Hello, Maria. Is my patient in the room?
No, Dr. Marcos, the HMP wasn't signed.
No, Stephanie told me she did it. He only had a banana in the morning.
I just checked.
No,
it's not signed, Dr. Marcos. I'm sorry. I'll bring him in as soon as you sign the HMP.
Please.
Dr. Marcos, I can't.
ASAP.
Sign the HMP and I'll bring the patient in.
Circulator, can we find a competent nurse? Hello, Greg.
Oh, hi, Dr. Marcos. How are you?
Have you commented about my birthday coming up?
Happy birthday, Dr. Marcos.
What are you scrubbing for?
Just a spine case.
Oh, your usual tectum to rectum? Oh, Stephanie, have you wished me a happy birthday?
Happy birthday, Dr. Marcos.
You know I'm the best looking person west of Lebanon.
That is true.
Hello, John. Have you fixed your tremor in the OR?
Hey, Dr. Marcos, happy birthday. You're really looking young, younger than 70. Happy birthday.
Hello, Ian. Aren't you going to congratulate me on becoming your age?
Happy birthday, Dr. Marcos. We can't age all as gracefully as you do.
Jean, happy birthday in my worst French accent.
Happy birthday.
Oh, Nick. Oh, my God. There is so much blood.
Happy birthday, Dr. Marcos.
Hey, Errol.
Hi, Maggie. Dr. Marcos just stopped by my office and he wanted to throw a COVID-19 party on December 16th. How do you think we're going to get that approved?
I'm sorry, a what? He wants to throw a what?
Hello? Hello, Dr. Marcos?
Yes.
Hey, Earl just stopped by my office, asking about a holiday party, a COVID-19 holiday party. Are you in your office?
I am in my office. Do you want to step by?
Yes, let me stop by. We need to talk about this.
Okay, I see you then.
Maggie, I don't know how we're gonna get this approved.
And how much?
No way.
And how much is this proposal for? I mean, this is crazy. And you want belly dancers?
$1,000.
And belly dancers? Like belly dancers. What is Dr. Marcos thinking? Oh my God, what am I going to do with him? Dr. Marcos.
Hey, Fee. Yes, I know, honey. Fee, sorry, but I have to go. I have lots of work to do. You know, I'm a very, very busy man. Fee, really, I have to go, okay? Bye. Yes, come in.
Hi, Dr. Marcos.
Maggie, Earl.
Dr. Marcos. Yeah. Earl says you came to him with a request for a COVID-19 holiday party on the 16th of December.
Yes, Maggie, this is the perfect time to throw a party.
Dr. Marcos, there's belly dancers in here too.
Well, yes, you know, the 2020 year, we have to end it. It was terrible. We need to celebrate it with everybody.
Never going to approve this? How am I supposed to get this approved, Dr. Marcos?
Well, Earl, you can get it from my Skull-based account. Maggie, you will take care of it. I'm sorry, I have to go. I have to go to the OR.
But Dr. Marcos,
Okay,
Marcos.
but I believe in you. Just word it something different. Dr. Marcos,
No holiday
okay.
parties.
Happy birthday, Dr. Marcos. We got you.
We can celebrate double next year, so enjoy the little party now and then, you know, get it going next year.
But sorry, still no belly dancers.
Happy birthday.
All right, Jock. Happy birthday, buddy. I've been asked to say a few words. You're supposed to be roasted tonight, so my job is easy. But you're turning 60. I mean, that's pretty amazing. People are astounded. They're saying, I mean, Jacques is really turning 60. I mean, he doesn't look like it, which is good. But he doesn't act like it. I really never did. But they don't understand that which you and I know, and many know. But I mean, you guys, Jacques was trained in the French system. You know, that's metric. So really, 60 is 16. You know, in Celsius. So really, if you look in Jacques' case, he turned 16, and then he stayed like that. So he's 16 plus, 44 years, of experience honing down that age zone. So yeah, I mean, you're really phenomenal at it, and you stayed so, and that's great. And I mean, I can relate to that. Yeah, I mean, right? But I mean, enjoy it, buddy. I mean, this is getting better and better for you. I mean, we all know how much.
Alan, we can't hear anything.
Yeah, it looks like the video froze, the audio, just the quality went down.
Are you hearing it now?
No, Stephanie told me she did it.
You hear it?
He only had it. banana in the morning.
I just checked.
No,
It's not signed, Dr. Marcos. I'm sorry. I'll bring them in as soon as you sign the HMP.
Please.
Dr. Marcos, I can't.
ASAP.
Sign the HMP and I'll bring the patient in.
Circulator, can we find a competent nurse?
Hang on a second.
Hello, Maria. Is my patient?
Sorry about that. Can you guys still hear?
Yeah, it cut off.
Now it's paused.
Okay, I'll try to get you back to where we were.
It cut off when Fadi was speaking.
Okay. It's just buffering. Jacques, this is your time for
I can, Alan. I mean, I am so I'm so surprised. I'm so touched by all the work that went into this. It's you know, what can I
wanted you to know
the reason we don't grow old is because we have friends like all of you. This is what keeps us all young at heart, at least. Let's see if Kathy can describe that peacock. No, I can't hear her. Can you guys hear her? I don't hear her.
Let's try again here.
appreciate all of the good times. Thanks so much and take great care.
Hello, Ingrid. I'm going to travel to Beirut, Lebanon. I'm going to my yearly reunion. I have many friends, you know, and I'm going to visit all my classmates. It was an excellent class. Of course, I was in it. Anyway, happy birthday, Dr. Morkos. I hope you enjoyed this big one, and I wish you many, many, many more.
Happy birthday, Dr. Marcos. Wish you the best today and always. Have a fantastic day. Enjoy with lots of laughter, Dr. Marcos. Happy birthday.
Jacques, what do you give to the professor, the scholar, the man who is everything? 60th birthday. I thought this would be appropriate. And this is also covered by your UHealth insurance, 80% of it. So think about it, and Carol can make your appointment. Happy birthday, and I toast to you for health, happiness, and a long life. We all love you. Happy birthday.
Jacques, happy birthday. You're the best. We love you at Jackson, and enjoy your day.
Ingrid!
Awesome. That's the video. My friend, happy 60th. It's been a great 25 years working with you. Looking forward to the future.
Alan, sorry, go ahead.
You can always ask for a recount if you don't believe it.
Alan, I mean, this is so special. I see my family's on. I see Isabella, who's awake on LA time. Isa, I love you. I see, of course, the rest of my family here. You guys, you know, this is what makes it so worthwhile, just being surrounded, as I said, by people like you. I'm very sad now that my accent isn't special. At least 4 or 5 of you can mimic my accent. That's terrible. And I thought I just had a unique accent. Very impressed. Ashish, as always, you excel. I love you all. I don't know. I can keep going on, but Alan, we're brothers. Thank you for putting this on. It's extremely special, virtual or not, or in real. It's very special. I feel it deep in my heart, and that's what life is all about. May we all grow old gracefully together. Thank you very much.
So I'm going to throw the mic over to Professor Wang. Thank you, Marcos, for joining us. Really appreciate it. And Mike?
Thank you, Alan. Jacques, Amy found this 3 liter of Lebanese wine.
You have that legendary New Year's Eve party. I'm sure this is not enough for you and Fiona alone, but we will miss it this year, but maybe in 2021, we'll look forward to that. Happy birthday, my friend. So we are absolutely delighted to be doing this virtually, although we need to do it in person to welcome one of the true iconic graduates of this program. We like to claim that Juan Uribe, who's at the Barrow Neurological, spent time here. He and Steve Vanny were the same. Steve and John Jagged were the same year, and they actually started at Cedars together, in the old Cedars before it became UM Hospital. And I got to know Juan in that year, and his career has just absolutely skyrocketed. He rebuilt the spine program at USF in Tampa. I'm proud to call him a friend. We've worked on many projects, including ISSG together, national meetings. Juan is going to be a future chair of the spine section, and he's president of ESMIS. So Juan, welcome back to Miami virtually. We're going to have you out for drinks sometime soon, okay?
No, thanks very much, Mike. And I will start. Dr. Marcos, happy birthday, my friend. And no worries, you're not alone with the accent. I also may need a copy of Dr. Green's prescription for sure. So anyway, I'm so honored to be here, Mike. Thanks very much for the invitation, Dr. Levy, and everybody at Jackson's. You know, I can keep going with names, go on and on. And you know, Steve, thanks to Steve, my beautiful English, that I always say thank you to him. And anyway, so yes, so want to make sure that this presentation is not going to be too long, because I recognize that more than half an hour becomes crazy. And what I'm going to share with you today is basically the lateral access to the spine, and where we started, where are we at, and how much this actually surgery had contributed to our field, specifically, spine, and how actually, not only that, but you will see that open new opportunities for us as a neurosurgeons conquer more on the field of the spine. So these are my disclosures, which obviously there is biases on it. So when we started in here is basically the lateral surgery to the spine is, instead of traditional way to do surgery on it, you don't go from posterior, you don't go from the front, you don't go a little bit posterolateral. Actually, this is a true lateral approach to the spine. And what makes a lot of difference is that you're able to deliver good fusion to the spine, a very interesting decompression of the neural elements, because instead of removing all the posterior elements, laminectomies and that, you just regain the disc height, and actually indirectly you release the neural elements, which is a very unique feature of this. And because of that, of the indirect decompression, actually you avoid the disruption of the posterior tension band that we know that provides good stabilization to the spine. And this one is actually very interesting. I mean, you will never have CSF leaks anymore if your surgery on the spine is more dedicated to lateral surgery. And which is very interesting as well is if you deliver the right implants, avoiding subsidence, you actually can physiologically restore the lordosis of the patients without getting into much kyphosis. And this is a slippery slope because it requires a good carpentry as well. So how the lateral surgery actually started, it was very interesting because I think Dr. Rosenthal still is practicing in Germany. Dr. Rosenthal is a Argentinian surgeon that spent most of his life in Germany, and he pioneered the endoscopic surgery to the spine. And he's been doing since the late 90s approaches to the spine, specifically in thoracic spine. And then in America, we have, like we'll say, the champions of the late 90s that were actually Dr. Levy and Dr. Marcos know Dr. Dickman very good when he was at Jackson, at Barrows. And then obviously Paul McAfee, John Reagan. And it was very interesting because endoscopy techniques at that time, they couldn't really get out. So it's now lately that actually Mike is leading this new movement when more technology is making actually endoscopic surgery more reproducible to us. But this is the origins of that. And then obviously, how end up taking the endoscopic instrument out and making more direct exposure. And actually that was Dr. Pimenta. Most of you don't know Dr. Pimenta. He's a neurosurgeon from Brazil. And actually he went to learn from Dr. Rosenthal in Germany endoscopic techniques. When he came back to Brazil, he figured out that it was, first, it was expensive because the technology that comes with endoscopy. And second, the amount of forces and the implant delivery and that part of the surgery was difficult. So he tried to adapt the similar principle, but actually using an expandable tubal retractor. And this is actually pictures of his first cases, as you see here. He was delivering these massive blocks of titanium, but you can see subsidence actually was almost the norm on these cases, which nowadays, if we have this kind of subsidence that we see here, we know that the indirect decompression will not exist. But it's very interesting because this is the way that it started. And then the approach was even more refined when, I will say, the lead complication of this surgery, that is the injury of the lumbar plexus. Actually, there was a way to map the lumbar plexus somehow, specifically the main branch, that is the femoral nerve, which is the lead cause of the morbidity when the complication happened. And it was delivering this ability to be able to place your retractor in front of the plexus and avoid the injury. So this is basically how the surgery is purely done. You go through the abdominal muscles, through the retroperitoneum, you get into the psoas. You use, in this case, you do it truly percutaneous using some monitoring system that be able to tell you where are the main branches of the lumbar plexus, and then you put your retractor up front, and then the rest is our carpentry. So, but at the end, you see, since 2001, actually it took at least 5 years to the first, I would say, street legal publication on lateral. And actually was lead, obviously Dr. Pimenta was there, but the whole work was by Dr. Taylor at UCSD in San Diego, which most of us know. And from here, obviously, it became probably one of the spine procedures that have more scrutiny in the spine world. And then there was something very interesting also with this surgery. And this, there were, a society was built around the lateral axis, what is called the SOLAS surgery, that started in 2006. And it was basically a group of friends believing in this procedure, getting together and learning from each other, but at the same time, trying to make an organized research. And this one delivered a lot of answers in a very educated fashion and actually moved exponentially the adoption of this technique, because it was honesty on the group. And then when there were a complication, instead of hiding it, actually was, can we learn from that? How can we move to the next one? And then obviously I'm humbled that I was part of a lot of the evolution and the validation, I will say, of this technique. And through the years, as you see here, papers and papers coming and attacking this approach from every side. And this one is actually, I was inspired to do this work when I saw the original anatomical paper by Dr. Levy, and then, obviously Steve Banney was involved, and Benglis actually was that, when he was resident, was the first author on it. And when I saw the paper, I was like, very interesting. There is one procedure where we are delivering an implant and we exactly don't have a full control of the anatomy. So then I start obsessive with this because the complications that I was having, they didn't have any sense. In other times is, for example, I was placing the retractor, let's say in front of the femoral nerve, like you see here in this dissection. This is anterior, this is posterior, the legs are this way, and the head and the arms are this way. So if this is L4, L5 disc space, and this is L4 nerve root, and this is the femoral nerve going down. So in some cases, you were placing your retractor in here, and when you were using the monitoring, the numbers were very low posterior, and then I was like, oh, I shouldn't put the retractor in here. But then I was trying to actually do it the right way, and the patients were waking up with no deficits. And sometimes I was having a really good numbers. Probably I was docking behind the plexus, and then the patients were waking up with deficits. So that's when, you know, the whole questioning about how to control this access started. And we learned through the years a couple of, I would say, fundamentals on the lateral access to the spine that if you follow them, it significantly decreases your rate of neurological, like lumbar plexus complications. And I'm going to explain you in these two pictures one major difference. So in the picture that we see here, in this drawing, actually we reproduce how the lumbar plexus looks when you look at the spine from the side. And if you're looking here, for example, if you're trying to do L4, L5, you have to navigate from the skin all these branches of the lumbar plexus until you get into the psoas muscle. And then your idea is, how can I place my retractor always in front of the plexus? I retract it from anterior to posterior because they belong to the foramens, so they tolerate retraction better from anterior to posterior. And then I'm going to explain you why actually the complications are so noisy when you perform lateral surgery instead of the classic T-leaf surgery. So in this insert on the right, this is actually an example of this, the Cambis triangle, as we know. So when you're doing a T-leaf, you're basically dealing with the traversing root and the exiting root. So you're basically dealing with one nerve root per level that you do, but which is interesting is you're dealing with a preganglionic neural elements. When you're doing a lateral, actually, by you injuring the femoral nerve, since it's a peripheral nerve, it's a postganglionic structure, actually, every time you injure the femoral nerve, they say, doing L4, L5 is the equivalent that you do a T-leaf on L2, L3, L3, L4, and L4, L5, and at each level, actually, you are hitting the root. So that's why it's so noisy, I would say, so much gross when you have a complication to this approach. So this one makes now this absolutely, they're two, I would say, two different animals, you know, the T-leaf and the lateral axis. And this was a problem on the beginning of adopting this technique. We were thinking that just for example, the T-leaf was a more refined technique, obviously before the lateral, and the mini open T-leaf using the Dr. Foley's instruments, I would say all the Medtronic system, the quadrant retractor that you guys are familiar with, there was a feeling that you just make the quadrant retractor that usually for T-leaf is shorter, make it longer, and then start putting it from the side and make the T-leaf cages a little bit longer, and then trying to use it from the side and use any kind of monitor. The problem is that unfortunately, it was not the same fundamental, and that one makes a big difference. So in here you see, for example, on this, I would say on this project, what we were trying to do is we were trying to find out if using the monitoring with directionality, as you see here on this little insert of the video, hopefully there is not too much delay because of the Zoom. You see here, when you go in anterior, in this case, you go in anterior, you have high numbers. So I'm stimulating, I'm standing on the back of the patient, stimulating anterior, you have high numbers. And then when you were stimulating posterior, you were having very low numbers. So what I was telling in that case is I was basically sitting right here. And this is the ideal area to place. But the next question was, fine. We were able to dominate, at least to be reproducible, always being in the front of the lumbar plexus, but why the patients still were having complications. And this is actually when it became very interesting, and to me became like, I just can't believe that in some surgeons can have 30-40% chance of complications, when on my hands is 5-10%, and a bunch of other surgeons. So we were trying to find out what are we missing in here. So and part of the presentation is just showing you a little bit of that story. So as we go through it, you will have a little bit answers of that. And then we find out that also initially the lateral surgery was basically designed for degen cases. But we find out that we were able to treat tumors. Then it was very efficient with trauma, since we can go lateral and help with the corpectomies. We were able also to adapt it to cases where like a kyphosis because of the osteomyelitis and so far. And then obviously we found a really good niche for this procedure on lateral, because of be able to deliver these big cages side to side, and actually when these cages go, tends to help a lot the coronal balance. Obviously, you will see later on with its own also limitations. And then at the beginning, it was limited only from L2 to L5, but you see right now, for example, is a really good option for thoracic disc herniations, is a really good option for I would say thoracolumbar trauma and other accesses, deformities so far. And then obviously the lumbar area. So you can see, you can go basically from T5 to L5 truly lateral. Nowadays, for example, the A-leaf, we can do it on the lateral position, which still is in A-leaf, but you just save. And this is something also that we see later on. So this is a really good example how this procedure works. You see the image on the left. It's a patient with a grade 1 spondylolisthesis, loss of this height, and translation, obviously, of the cranial vertebra. You see, just by restoring the disc height, the amount of decompression that you have without absolutely not touching the posterior elements. And we like this is because we know that the posterior elements, multifidus, all these muscles, when you touch them, at least on the short term, they give a lot of pain and morbidity to the patients. So when you perform this surgery exactly as should be, patients has an amazing outcomes and they go early. So when we look, for example, at the retractors nowadays, each company will say has 3 or 4 different generation of that. And as you see here, they come in different colors, flavors, you name it, but they have one common denominator. Probably is an expandable tube, and most of the time is a 3-blade configuration. And also in common, they have that the footprint of the blade is extremely small in terms of preventing complications. But then again, the point is the surgery is just not a retractor and a cage. It's more than that. So and then we look at the implant, for example, this became actually like a specialty implant surgery. It's very interesting. It's like when you play golf, you have a different club for different shot. So in here you say, for example, you have cages, standard peak cages for patients that they don't need too much lordosis. You have cages with hyperlordoric angles when you need to provide lordosis on the ACR procedures. You have corpectomy cages. You have, for example, cages that you require fixation in some cases. So as you see here, there is a big palette of different options, and that has been created through the years depending on the needs of the case. But then on the other side, you see here, this is actually all my complications through this. So if you ask me, I've been having absolutely any complication probably that is on the spine. I've been lucky that only what we call the catastrophic ones, which is the bowel injury of the vascular injury. I haven't had it up to date. It may be next week. But what I can tell you is, as good as this procedure, if you don't treat it good, you can have a significant complications. For example, look on this picture. We created a new type of fracture, this split fracture in the coronal plane by placing these plates where you are creating between the cage and the screw, you create this stress shield area, which creates this type of fractures. And then you see here in this case, I mean, classic atrophy of the femoral nerve injury. In here, you see this implant migration, this corpectomy, you see the classic subsidence. And this one, for example, was a thoracic case. You see here this nice gift, which is a hemothorax. So this is a surgery that actually, if you don't do it right, there's a huge potential for a lot of complications. And then this was probably what I think is the most important, I will say, contribution to the lateral surgery. You know, anatomy was important, the cages, the retractors, you name it. But I would say from this study, actually, we had probably the best answer what I was coming from. Why patients, even without appropriate retraction of the lumbar plexus, wake up with deficit. So in this trial, actually, the original intent was to figure it out if you put a monitoring on the retractor on the posterior blade, and you put an EMG lead, and you try to monitorize all the case with EMG, were you able to monitorize one, nerve health, and second, predict any injuries. And when we started looking at the data, we find out that actually the value of that EMG was very minimal to none. And because we recognize that the only role of the EMG during this surgery is basically helps you to identify where are the main motor branches of the plexus. And after that, if the nerve is gonna get injured, EMG has absolutely no value. By the time that you have changes on the EMG, it's already too late. But what we found that was very interesting is that the patients that end up with a femoral nerve injury, like a real lumbar plexus injury, they have something in common, which was time of retraction. The time of retraction in most of these cases were more than half an hour per level. And this one is a huge conclusion. And I'm gonna tell you why. It's because after that trial, we finally put together I would say the requirements to deliver a good lateral surgery. And we find out that you actually have to control 3 variables. One is the direction. Direction of what? Direction of retraction of the lumbar plexus. So as long as you are able to put always consistent your retractor in front of the femoral nerve and the main motor branches, you are protected somehow, but that's not enough. So how you do this? You can use EMG monitoring, you can use the direct vision, you know, you can open the retroperitoneum, dissecting, move all the fat, get into the psoas, find nerves, and trying to put it in front of the biggest nerve that you see, which is a good option. In my own concept is I like make it percutaneous through a small incision, a slick using EMG technology, but doesn't mean anything. Okay, second one is time. As long as you find the nerve and you retract it and you stay less than half an hour, I promise you, your rate of lumbar plexus complications is going to drop significantly, very close to 0. Not 0 because it doesn't exist. And then third, the amount of retraction. Okay, if you get into this space and you open the retractor from here to here, it's great for you, for the surgeon, because you see a lot of things, but not good for the patient. And to be honest, you should be able to open the retractor only the size that you need to place the implant that you're doing. There is no reason to have one blade in here and one blade in here, you know. You start dealing with the segmentary vessels, you're retracting the plexus more, and then if you combine big opening the retraction, more than half an hour, and not able to, you will wake up without complication for sure. So that became very interesting. The problem is obviously not everybody gets trained in the same way. Not everybody can control to be retracting the plexus less than half an hour, which I will believe is the safest side. Ideally, once you put the retractor and you put the shim, you should be able to get out of there in less than 10 minutes, which is very reproducible because I see, our residents and fellows can do it. But then, because of that, then there came more variants, and the variants were obviously the classic trans-psoas, and then we start talking about pre-psoas, ante-psoas, and this one when the O-leaf and all these variants came, and I'm gonna go a little bit into that. So the classic approach was trans-psoas, which they have some variants. You can do it less invasive, means percutaneous incision, go through it. You can do a mini open, as you guys know, the shallow docking, the direct view, or you can even do open, classic lumbotomy, open through it, get to a retroperitoneum and find that. And then we have the pre-psoas approaches, where you take advantage of this corridor that is in here, and you have to deal less with the lumbar plexus, but you have to understand you're gonna deal more with vessels with different structures that can be injured, as I will show you later on. And that's the O-leaf and the lateral A-leaf, you name it. So, first thing, why the pre-psoas approaches exist? This is the best answer. It's the direct result of the trans-psoas neurological complications, mainly at the lower levels. And basically, the O-leaf or the pre-psoas approach is an A-leaf with the patient in lateral position using a tubular retractor, not the classic book Walter retractor. And, it works good. For some surgeons, works very good. And which is interesting is this is not one excluding to the other one, We love because all of them are still lateral access to the spine. So, but watch this. When you go pre-psoas, again, we have three big variables to control that are different of the trans-psoas. One is orientation. Orientation on O-leaf is a little more difficult. If you do it under navigation, it's easy because you know exactly where you're going. Second, vessels, ureters, and all visceral structure. You have to intimately deal with them because you are actually retracting pretty much them. And then, obviously, the other one is the end plate coverage. Is if you are truly oblique, usually you're afraid to hit the contralateral nerve root, and then you end up delivering I would say, a short implant, which is not gonna be good to prevent subsidence. So as long as you are aware that you have to cover your full end plate, that you are able to control and handle the complication of significant vascular injuries, then it becomes a really good surgery. So in here, in this picture that we actually were able to put together, it's just showing basically, you choose, I would say, your own poison. If you go trans-psoas, you're gonna deal more with the lumbar plexus. If you go pre-psoas, you're gonna deal vessels, ureters, more visceral structures. However, if you go trans-psoas, you can have vascular injuries, and if you go pre-psoas, you can have also lumbar plexus injuries. And you have to understand, because sometimes this industry people, they come to you and they say, oh, you go pre-psoas, you will never have a vascular injuries. Or you go trans-psoas, the only problem that you will have is just lumbar plexus injury. You will never have to deal with that, which is not correct. So what in this case, in this paper, what we did is we tried to pull out most of the papers that were on the literature looking at pre-psoas and trans-psoas approaches. And we tried to find all the complications that were reported. So using here, both procedures, they share a lot of complications. And which was interesting is that actually, for example, when you go pre-psoas, you still have neurological deficits. And obviously pre-psoas, you have more vascular and different complications because of the location anteriorly. But then, obviously, trans-psoas, the lead complication was the nerve injury. Again, this is a good example how the surgery works. Probably the best application is DGen grade 1 spondylolisthesis, which is very common. Using here, just restoring the disc height. You see the size of this cage, for example, is only 8 millimeter height. You don't need to go 12, 14, which is going to promote subsidence, because what you want to have is these end plates post-op absolutely pristine, because that way you maintain, and this indirect decompression is sustainable. Using here one of the cases, long-term, but then I'm gonna show you what actually the lateral axis has contributed to the field of the spine that is unique. So the ACR, so ACR is basically going from the side, cut the anterior longitudinal ligament, then fish mouth the space and place a cage that in average are 20, 30 degrees. You know, if you have expandable cages, you can play with that. But this one actually opens a huge window because then minimal invasive, we were able to treat deformities. And that was one of the biggest problems on lateral surgery at the beginning. In some cases, for example, like this one, just delivering a cage with 10 degrees was not enough to get lordosis. But using here, just cutting the ligament and placing a hyperlordotic cage, then you have a really good results. And then, you know, obviously you start expanding and you do 5, 6 levels, and then you use percutaneous screws, and then you start actually delivering surgeries that can compete head to head to the, you know, standard open deformity. So the ACR open a window to be able to deliver deformity using less invasive techniques, which we love it. Because trauma was amazing also, you know. Before we start doing the lateral access, the mini open access to the thoracic spine and lateral, cases like this, big bone fractures with patients with some, I would say, indirect neurological deficits, these patients, we were accessing anterior, and don't forget, used to call the, you know, lateral access, the access surgeon, cardiothoracic surgeons, they go, they open the patient half, what we call the sharp bite incision. They give you a tour through the chest, show you the heart, the azygos, whatever. And at the end, you end up working in this little space. So, which was very interesting. And then you had to chase them. Where are them? Can you come and close for me? Can you manage the chest tube? All these things. But which is interesting is doing the lateral access, actually, we can go directly with the problem is, we don't need the access surgeon because the anatomy is so descriptive and so right there that actually you can deliver a really good job as using here. You go exactly where you need to be. There's no need to deal with visceral pleuras and all these things. And most of the cases, you can get away even without using chest tubes. Using here, these implants work very good. You can expand it, go from end plate to end plate, and then also helps to avoid this pistoning that we have traditionally with the circular cages. So just the fact that you have these wide implants, it helps to prevent also subsidence on these cages and do those. Okay, next one. This is, to me, is I would say the most, as a spine surgeons, I would say this is the most elegant surgery that we do. And I like it a lot because as a neurosurgeons, this is probably a surgery when we really use all these 6 years of training, you know, been sitting and watching Dr. Morcos and Dr. Harros dissecting the sylvian fissures and all these far laterals, all the name. This is actually the only surgery where I can use my microsurgical skills, something that we learn from our, you know, our giants, I would say, that we have to keep it as a neurosurgeon. That's why we have to be proud and still be neurosurgeons on the side of the spine. We cannot become an orthopedic guys. And I apologize for Dr. Level and more orthopedic guys in here, but I will say is we have to be proud that we have the skills to be able to perform microsurgery and translate it to the spine. And as you see here in this case, for example, we go exactly with the small access with the tube. We are able to mobilize, in this case, for example, the aorta moves anterior, and then we go. Once we get deep enough, we get the microscope, we find the dura, we take the pedicle down. As you see here, the results are amazing. So this is probably, I would say, the most elegant surgery that we can deliver as a spine surgeon, because as you know, the complication of a giant calcified disc on the mid-thoracic spine is usually paralysis. So how can you go there with a small incision in and out and you deliver a good procedure? So that's what the lateral surgery in this case actually can do it. Then what we're looking here is, in this case, for example, is another really unique application of the lateral surgery. Patients with previous surgeries that had developed a adjacent segment failure, in the past, it was a big deal because you have to open everything, find the previous hardware dealing with the scar tissue, try to find a way to get there. In this case, using here, you access from the side. In this case, you put the biggest cage that you can have. In this case, is a 26 millimeter cage, which in average we use 18 cages. But what you do is in here, you get good indirect decompression, and then obviously you deliver a really good anterior column support. And this surgery, skin to skin, if you don't do nothing posterior, is under 1 hour with 20, 30 cc's of blood loss. This patient go home the same day, which is a big disruptive alternative to the traditional surgery. So this is another example when lateral surgery actually been helping the field and the outcomes of the patients. Okay, so now let's get to the last part of the talk. So this one is what is next. So this is what we're doing right now. So we're talking about single position surgery. What does it mean? With the patient on lateral position or on prone position, we are able to do lateral access to the spine, and at the same time, all the posterior access to the spine. So basically, we are able to do a 360 approach to the spine without losing that much time between positioning of the patient, one stage and the other one. In this case, for example, using here, this is the 5-1, which we have the patient on lateral. This is the right side up. So you see the incision for the A-leaf on the 5-1. So first stage, you do the A-leaf with the patient on lateral. Then the next part is still with the patient on lateral. You do all your lateral job. You put your cages lateral, and then you put your screws percutaneous on lateral position. Obviously, it's demanding technically. With the new technology, it means navigation is becoming more friendly. Robotics can help, but in my hands, the robot is actually making me slower. So I try to do in a very simple cases, but navigation definitely is making this more reproducible. And you see that case, for example, you can deliver multi-level lumbar fusion and in, I will say, a good way, saving a lot of timings. So this is what we're doing lately. This is actually a recent paper, which I think it just published this year. So what we're doing right now is actually we're trying to do the lateral access in prone position, and then be able to have especially the big advantage is, number one is the time savings, because as we know, time is everything. Everything that I see that I'm saving time, to me is actually on target. And second, obviously, the advantages of having the posterior position and be able to do, for example, laminectomies when you really need to do in some specific cases. So you see here, this is the patient in prone position, we mark the incision, and then you see here, working sitting position, you get access, you do your interbodies, and then, which is very good, as you see here, have one of the residents doing simultaneous approaches. He's doing the exposure. In this case, was removing some screws and doing some laminectomy. At the same time, I'm doing an access lateral to the patient. So this is actually a really good time savings and efficient way to do it. So in conclusion, the lateral access to the spine is a very versatile procedure. The most common complication, as we know, is nerve injuries or vascular injuries if you're going on the pre-psoas approach. Nothing can substitute the meticulous surgical technique. This surgery requires a lot of nuances and technical skills that you can develop. Everybody can develop as long as you do it. It requires a very good acknowledgement of the regional anatomy. If you don't know where you're going, it's hard, and the best example is wake up in the middle of the night in your home to go to your bathroom. You don't need to turn the light on. You know how to move, how to get there. I put you with the same situation, but in a hotel that you never been there. I bet you that you hit the bed, you hit one door. So this is exactly what is this surgery about. If you know the anatomy of what you're doing, I promise you, the outcomes are gonna be good, very good. And then obviously, if you're trying to do in single position what it's trying to do right now, you will going to improve and save a lot of time, decrease cost, and spend more time whatever you want to do, your family, your hobbies, you name it. Thanks very much. If you want to see more details, you know, we usually post cases and interesting things on LinkedIn, and also Mike and his podcast. Social media is probably the best way to connect in now in these bad times. Thanks very much, Mike and Dr. Levy and everybody.
Thank you, Juan. That is absolutely fantastic. Just for the residents and fellows, I think what you can see here is that what Juan has done is sort of the classic and prototypical, archetypal example of the American surgeon, even though he's Colombian. He has taken this procedure instead of in breath like the Europeans, where I say I can do every kind of surgery, and when Juan can, he's taken this down so far down this rabbit hole that Juan truly is one of the top 2 or 3 experts in this area in the entire world. And so I would recommend that the young people listening may consider that as a possible model of how you would build a career, hoping, of course, that pleading that one day your career would be as storied and spectacular as Juan's is. So congratulations on not only your talk, but an amazing career, Juan. So let me open up. I'm sure Dr. Levy has comments and questions, and to the rest of the group.
No, I mean, amazing, Juan. And just like Mike said, you have been a Colombian pit bull on this topic. Obviously, you're a fantastic surgeon in all spheres, but the way you've taken the lateral to the next universe, you know, you need to be congratulated. You mentioned some of the early papers that we published here. 3 questions come up. You know, when we looked at motor injuries and specifically femoral nerve injury and pseudohernia, you know, we found obviously that 4-5 was the highest level. Really only 2 injuries, and they were all very, very early on, and they were all related to the use of a Steinman pin for localization. Not so much time of traction and things like that. And you know, we've continued to accumulate the data. We haven't had any, to my knowledge, at the university at least. And there have been cases where we've actually aborted. I mean, I've aborted, where it's just impossible to get the procedure done without significant retraction. And since there are all alternatives, I think that that's a reasonable mechanism to avoid as well. You know, and it happens probably 1 every 100 cases. Comments?
Yeah, exactly, Dr. Levy. First, I want to tell you that you know, I am where I am because I've been I'm made by you guys. I owe a lot to all of you that gave me the hand and my basic principles. You know, every time I do in a surgery or something, I always have a little bit of Levy in here, Heros in here, Green, Marcos. You know, it's amazing how much I have. You know, where I am, and I never forget my roots. You know, we as a Latin culture, we never forget where we're coming from, and this is something that I will be grateful. The second thing is, Dr. Levy, is yes, that's very interesting. And as I told you, the initial anatomical paper that actually inspired me to do that is the paper that you put together with Benglis, and I think Steve Banney was also in that paper. Yeah, and then what is interesting is that we say we can have direct and indirect injuries to the plexus, yeah? So if you hit the nerve with a club or something, obviously it's a direct injury, but the one that is more frequent is the one that comes from indirect, you know, retraction for too long of the nerve that get ischemia, who knows? You know, I wish to have the Miami project with me. We can make a good study. Why, you know, what is actually when the nerves start getting injured and what is the main mechanism, at what time it becomes irreversible, yeah? Because a lot of patients, when it's just the myelin, I would say the neuropraxia, in 6 weeks, they get good, but some patient is permanent, and that patient, how can we avoid that big patients? And the other thing is, which you bring very important, is I'll do a lot of T-lifts still, you know, it's not like my only surgery is lateral, and everything starts and I usually when I have the fellows and residents is we look, the lateral surgeon, I would say, look at the MRI axial different than the regular traditional spine surgeon. The first thing that I look when I look an axial cut on the MRI is what is the psoas relation with the vertebra? Where is the bifurcation of the vessels? Did I see any transitional features of the psoas? Because if I have that, I don't do the lateral access. So I'm avoiding a lot of complications just by changing the approach. And this is what you just mentioned, which is, I wish that I had more time to go over that. And but which is interesting is that we still, Dr. Levy, don't have a clear explanation on that. And we need to go actually, I wish to, if I have some residents, some fellows on day that put a good protocol, good funded on initially in animal models where we can replicate the injuries that happen with this and then look right away at the microscopic level. How can we avoid it? Because the process, how this thing happened, So
the other question was the pseudo hernia. What is the nerve injured in pseudo hernia? I know you had a publication on true hernias, which are pretty rare, but
yeah. Yeah, the true hernias one was very interesting. It was 2 years, the same fellow, the same resident. It was a closure issue, But I decided to put the paper together, something that I learned with Dr. Heros, Don't be ashamed of your complications. Identify it, learn from it, and let the community know. So that one is easy to fix. You just need to, for example, you unbreak the table, make sure that you close good, and then incisional hernias. The other one is the pseudo hernia. I believe it's a combination of couple. I think the main culprit probably the subcostal nerve, that is just, and then obviously the ilioinguinal and hypogastric somehow. It's a complication that is very hard to control as well. The only good thing is that patients tolerated, I would say, better than the femoral nerve injuries, unless you're a young female, that wants to put your bikini back. And a lot of times it's reversible. There is I would say the only way that we can prevent it is at the time of the muscle dissection of the abdominal muscles, especially when you're working close to the subcostal, like L2, L3, L1, L2, when you are close to the 12 rib, make sure that you see the nerve, you dissect it, and you move around it. That way. The problem is when you go right away with the bobby, because nothing else that you can do.
Final question, so I leave room for other people. There was a publication by the UCSF group probably about 4 months ago, Dean Chu and Praveen, and they basically published that, the long-term results of indirect decompression, are not that great in their group's hands. I don't know if it's because they're undersizing their grafts anteriorly, but, basically just doing what you discussed, indirect decompression through a lateral approach, plus or minus screws, their results were not great. And I wondered if you could comment about that.
Yeah, and that's a great question. And, we have that question all the time. And this one comes, Dr. Levy, from a couple of things. One is you have to learn to identify what are the predictive factors of indirect decompression, So in other words, indirect decompression is not for everybody. And we have a paper coming right now that finally, after many years, I was able to find what I was thinking predicts indirect decompression. And for example, we found that the number one predictor is obviously loss of this height. As long as you have a loss of this height, you can have indirect decompression. The second one is vacuum phenomenon. Also, when you see vacuum phenomenon, it's also, they tend to respond good to indirect decompression. And the third one is when you see hyperintensity on the MRI, on the T2 sequences, on the facets joints, and obviously spondylolisthesis. But I can tell you what happened. Since I moved to BNI, so my data became, I was able to say, let's make a very nice database from now on because I start from scratch. So in the last 3 years, I pull out all the lateral cases, all the indirect decompression that we've done. And this is also paper that just get approved. I think, Mike, I don't know if you're reading that, maybe Mike approved it or something, appreciate it. So basically what it was is, in my hands, because I pay a lot of attention, especially to prevent subsidence, because you subside, that's what I say, too much subsidence during the talk. When you subside, it's a good chance that you lose your indirect decompression. In my hands, our group, our numbers are, watch, this is very interesting, 5% of failure of indirect decompression. Actually, the title of the paper is When the Indirect Decompression Failed, and it's 5. And then, which is more interesting, this one is Dr. Levy, of that 5%, we bring it back to the OR, but only 50% of them actually got better. So there is still a group of patients that they will never get better with direct or indirect decompression. You tell me what's going on, but the problem is it's not for everybody. Just to finish your answer. Second, you have to learn to identify where are the predictive factors, and third, you have to be a perfect carpentry on this. You have to be a really good carpenter. You don't want to oversize, it's a lot of little things. So that's why I think it varies practice to practice. But, obviously, I don't want to come in here like I know all the answers, It's a lot of things that we don't know, yeah?
Hey, Dr. Uribe, thank you for the talk. Oh, sorry, Timur, I see you popping up there too. Quick question. This is Shelby. I'm a chief resident this year. I was wondering, how often are you using standalone cages versus backing them up? And do you have like a sort of reason that you'll do standalone versus not?
Yeah. The short answer is around 10% of my cases are standalone. There are very unique demographics, I will call. I like to use it in young patients that are very few of them that, you have to fuse them because of they try everything and they actually get into a point that you have no more options. They have good bone, so that patients are good candidate for a standalone. On the other end is the patients, the older patients with significant comorbidities that adding, like osteotomies or complex posterior surgeries, the benefits are going to be way low than, way low than the risks. For example, patients, I say octogenarians with scoliosis and back pain, intractable. So this patient, for example, you put 2-3 cages standalone, it's a surgery that has a very low morbidity. They go home for sure next day, and you can stop the progression of the scoliosis, and in some of them, actually, they get some relief. That's my biggest group of standalone patients. And then some adjacent segment failures on degen cases, as long as they have a perfect sagittal balance, because if they don't, they will subside really bad because the forces are too much on the anterior column.
Can I make a comment? Can you hear me?
Yeah, Dr. Harold, for sure. Glad to see you.
Anyhow, I frankly don't know even where the spine is located, but I can tell you that I really enjoyed this talk. What a beautiful talk. And I want to say, Juan, how proud we are of you, even though I had nothing to do with your training as an alumnus of Miami. We're just immensely proud of you. And this is a spectacular lecture. And I think I'm going to think about beginning to do some of this. Maybe I can spend a little time with you at the BMI.
You're welcome.
Surgery, beautiful. Thank you.
No, thanks to you, Dr. Harold. I owe you a lot. You gave me the hand when I needed the most. So what's going on with you, Timur? I see you there.
Well, actually, you answered the question because Shelby asked exactly what's been on my mind too. Minimizing, the exposures and the intervention on the patient, and when you can get away with those standalone and not even backing them out with the lateral screws. That's still acting on my mind, and in a way, you've answered some of it. But of course, I'm sure there's more to it than what you already said. So, if you have any other comments.
No, the other thing is that don't forget at the end is trade business between you and the patient on the clinic. This is what I always say, the modern spine surgeon should be able to sit in front of the patient and offer open and minimal invasive techniques unbiased. I don't want the surgeon that sits with the patient in front like, oh, I don't do these MIS techniques, they're not good enough. For the residents in here and everything. That's why it's so important that for you guys, you will be privileged that you can grow up with both techniques. It's like if you're a vascular surgeon, be able to offer endovascular and surgery at the same time. So obviously, every time it has its own bias, but I will say you have to keep it. If you're a golfer, lateral surgery is a really good club in your back. In my case, it's on the 7 iron. For someone else, it's the 3. But you have to know when to use it and how to use it.
Thank you. Great talk, Doctor.
Yeah.
Always.
Yes, thank you.
Juan, we want to thank you again and to respect your time. I know you need to head to the OR, and so do we. So thank you very much. And when this is over, we're going to have you back to Miami with all the other VPs of 2020 so we can have some drinks together, okay?
That should be great. Thanks very much again, and everybody have a good day. Thank you for the opportunity.